Assalamu alaikum and welcome back to another episode of What's Up Doc. I'm your host, Dr. Aalia Al-Barwani, and I'm a board certified physician. My show, What's Up Doc, is a production of Muslim Network TV, only Muslim focused network broadcasting in North America. You can find our shows on our website at muslimnetwork.tv and on our YouTube page at youtube.com/Muslim Network TV. You can also find us on Roku TV, Apple TV, Fire TV, and Galaxy 19. Today's show is about a topic a lot of you in the audience may not have heard of, and that is endometriosis, a condition that affects up to 1 in 10 women by some sources. Joining us in that discussion is Dr. Tayyaba Ahmed. Dr. Ahmed was born and raised in Long Island, New York, where she completed her medical residency at the New York Institute of Technology and residency at the New York College of Osteopathic Medicine, Northwell Health Hospital in Long Island, and the NYU Langone Medical Center Rusk Institute for Rehabilitation in New York City. A board-certified physical medicine and rehabilitation physician, Dr. Ahmed is also a fellow of the Academy of Physical Medicine and Rehabilitation and a member of the International Pelvic Pain Society. Welcome, Dr. Ahmed. Thank you for joining us.
Thank you so much for having me.
Of course. I was really excited to see the depth of all of your research and work that you've done in pelvic pain syndromes and in endometriosis and the treatment that you provide for patients that you had to be the perfect candidate for our episode today.
I'm very excited. Obviously, you know how passionate I am about helping women with these taboo syndromes that people are not talking about.
Absolutely. And so, as I mentioned, a lot of people have not heard of it, and even if they have, like you said, are not even talking about it. And so I'm excited to start off by explaining to our audience what is endometriosis, because a lot of people in our audience may be experiencing it, but don't have a name for it. So let's start by defining what it is and maybe going over some of the symptoms.
Sure. Endometriosis is a condition in which tissue that looks like the tissue inside of the uterus, so it's not the same as the tissue in the uterus, it's not the endometrium. It's similar to it, but it's outside of the outside of the entire uterus. So it's not in the uterus, which is like the number one thing to understand. A hysterectomy would not treat endometriosis because it's not in the uterus. It hangs out all over the pelvic cavity, but it's not limited to the pelvic cavity. It actually can be everywhere. It could be on top of the bowel. It could be on the bladder. It could actually be on the lungs, which is called thoracic endometriosis. It could be on the diaphragm. It's basically found everywhere. And essentially, it's almost like a benign cancer that spreads and grows, and it's hormonally driven. Because of that, when patients have, their menstrual cycles, they often feel pain in those areas where they have endometriosis. However, it's not necessarily correlated to their menstrual cycle. For some patients, it can be all month long, even if they're not having a menstrual cycle during that period. There are different stages of endometriosis, which can make it quite complicated. And the unfortunate thing about endometriosis is the only way to 100% definitively diagnose it is through a laparoscopic surgery, taking the tissue out and having it evaluated by a pathologist to confirm the diagnosis of endometriosis.
A lot of information that you just shared there that we're going to try to break down, but very valuable. So essentially, what it is tissue that's similar to what lines the uterus found outside the uterus. Now, why? It may be obvious to some why that might be a problem, but why don't we just go into simplifying why that could be a problem? You mentioned pain being an issue. And so why does it matter that this tissue isn't where it's supposed to be? What are the implications of that?
So, number one, if the tissue is causing pain, you're going to have abdominal, a person typically presenting with abdominal pain. So it's hard to live with that. Many patients will think that their pain is either gynecologic, it could be considered gastro, related to their GI tract. And that's very common where patients are now going to a GI doctor and saying, I have abdominal pain. It's not and they don't necessarily correlate it with their period. So they're not they're not understanding that. So they're often diagnosed with IBS improperly. It could be on the bladder. It could cause urinary frequency and urgency because of that. And they also might miss the fact that it's correlating with their menstrual cycle as well. And so they might have menstrual urinary symptoms all month long. So it can affect the bowel, making you feel constipated, abdominal bloating, that pain. It can also present with the urinary frequency, urinary urgency, the inability to completely void, or that sensation of not fully emptying their bladder. So it can also affect, sexual function, causing pain with intercourse. For many patients, it could be with a superficial penetration or deep thrusting. And then it can also cause problems down the line. It can cause fertility issues. If that tissue is on the uterus or around the ovaries, it can make implantation difficult. It can, also make the egg quality of the ovaries not good. So many times patients, can have or carry a child, but their egg quality might not be that wonderful, which can make it difficult for them to release an egg, or the egg that they do release may not be of good quality, and they may miscarry because of that.
Wow.
I mean, there's no definitive way to tell whether a patient would have fertility issues or infertility issues. And it can also cause menopausal problems because of the hormones. And there is a risk that endometriosis can become a cancer. There's a small percentage of it can become an ovarian cancer, but it is important to note that risk exists.
Wow. So essentially what I'm hearing is that wherever it lands, it can wreak havoc on that system or that area. And so somebody who presents to you with a constellation of different symptoms, because there are other causes for a lot of the things that you just said: urinary frequency, going to the bathroom a lot, or that feeling that you haven't completely emptied your bladder. There's a differential diagnosis that's pretty long, including something as simple as an infection. And so it makes it, from what I understand, really hard to diagnose, and from what I understand, because it can mimic a lot of other things. By some studies, I read that it can take between 7 to 12 years from onset of symptoms to diagnosis, which I couldn't imagine that with any other condition like diabetes or high blood pressure, where it eludes even medical professionals and diagnosis is delayed. So let's talk a little bit about that, especially in your clinical setting. When patients come in, what kind of things, or maybe because of the work you do, you're already clued in and already suspicious for endometriosis, but what kinds of things do you usually look for, or to distinguish symptoms that may be related to, like I said, other things versus endometriosis?
Well, because I also treat pelvic pain, many of our patients have pelvic floor dysfunction. So pelvic floor dysfunction is a condition in which the pelvic floor, many people don't know they have a pelvic floor, it travels between the pubic bone to the tailbone, and it holds up the bladder, the uterus, and the descending colon. In males, it holds up the prostate. So both men and women have pelvic floors, and they can have pelvic floor dysfunction. Because of this, when patients have pain, they typically clench their pelvic floors. They clench their abdomens, which is very closely attached to their pelvic floor. And because of that, many times patients are diagnosed with pelvic floor dysfunction, but they are also diagnosed with endometriosis. And just by treating their pelvic floor dysfunction, a lot of their quality of life improves. So there is a huge overlap with the pelvis, because the pelvic pain is anything between your pubic, between your belly button and your knees. And that's a pretty decent amount of organs and musculoskeletal parts, including the pubic bone and the hips. So there is a lot that happens in that area. So just because someone has endometriosis, which, like you said, it takes 7 to 12 years, because there is such a mixture of diagnoses that overlap. Also, it's important to understand that 1 in every 10 women has endometriosis. That's a huge number of people. And it's often misdiagnosed especially in people of color, because they're not necessarily taken seriously, or there is a taboo around seeking help for menstrual syndromes. So it's very important that we're speaking about it, and this is, why being on this audience today is so important, because we want to get the word out so patients are willing to seek help.
Absolutely. I agree with you. And that's one of the things I love about this platform is the ability to share and talk about our health in a way that is inviting and educational for our audience to to think about and speak to their providers about. I completely agree with you. There is this cultural understanding that women go through certain pains and we just need to grin and bear it. And that includes menstrual pain, labor pain, and we don't have to. We have, there are pains that are normal, and then there are pains that are pathologic. And this definitely is. And so along that line, I just want us to underline that even though you've mentioned some pretty common symptoms that may be endometriosis, such as the urinary issues or the constipation, etc. There are things that look like it that a woman goes through every month, like we said with menstrual pain. And so sometimes women come to me and they're complaining of really bad menstrual pain where they're unable to go into work. They're suffering from their menstrual pain. And as a family primary care physician, I'm investigating, and at times I'm going to have to, of course, refer to a GYN, and we'll get into the diagnosis in order to make that diagnosis conclusively. But there is a high level of suspicion. For a lot of women, at what point should we be explaining to them that their menstrual pain is not normal? When should we say, yeah, maybe you need to go talk to your doctor about that because that is not normal? So in your clinical experience, if you could share with us what kinds of things are red flags.
So, the classic story that I hear, it's the 16-year-old or the 13-year-old or 14-year-old girl whose first period was maybe really bad, but then more importantly, the next year it ended up being really bad, where she's missing school, she's missing work. When she's older, she may have gone on birth control. Notice that the birth control helps. In some scenarios, the birth control does not help. Anyone for sure that has to miss school or work because of menstrual cramps or pain, that's not normal. You should not be vomiting because of the pain. You should not be passing out from the pain. You should not be on the floor in a fetal position because of the pain. There is, if you can take a Motrin and your pain goes away and the next day you're totally fine, that does not necessarily guarantee you do not have endometriosis. But if it is something that you can live with, you're tolerating, it does not bother you, you're not missing work or school, or it's not disrupting your lifestyle, that's great. But if you're also having affiliated symptoms with chronic constipation, abdominal bloating where you look like you are pregnant when you're not, you're having pain with intercourse, anything hurts with penetration, a tampon or a speculum exam, if you're having any of these plus urinary symptoms, frequency and urgency, or burning, or abdominal pain when your bladder feels full, these are not normal symptoms. And when usually you can say yes to 4 or 5 of these things, I personally will diagnose someone clinically with endometriosis before they have a surgery, because 90% of the patients I say that I think you have endometriosis to end up having endometriosis. I mean, I'd even go as far to say 95%. Majority of these patients have endometriosis, and it is so common in women that I'm usually not wrong. So
that's a pretty high statistic, Dr. Ahmed. And so just to kind of recap, essentially a lot of it is the severity of symptoms. But even then, if the severity of the menstrual cramps is not there, but you have these other symptoms that you mentioned, then there should be some suspicion for that. Now, you mentioned as young as 16-year-old patient that could have it. So does the condition span the reproductive ages then, or at what age should do you more commonly see it?
So we see it more in reproductive age. However, we know that they are found, endometriosis is found in fetal cells. So it's actually genetic. It's something that's passed along maternal lineage, and patients are seeing it even before they have their first menstrual cycle. Many patients, not many, but there a handful of patients have told me that when they were 9, 10, before they had their menstrual cycle, they would have abdominal pain, and their parents would constantly be taking them to doctors for their GI system because they were chronically constipated. And then endometriosis kind of came into the picture when they were in their mid-20s. There's also something called silent endometriosis, which is not really silent, mostly because many of these women have endometriosis their entire reproductive life, but when they are put on birth control, their symptoms are essentially masking their pain, and so it's silenced. And then when they are off the birth control in their 30s, 40s, trying to get pregnant, they have trouble getting pregnant because the endometriosis, in fact, grew and caused issues with their reproductive tract.
Wow, that is fascinating. I did not realize that like as you described, in fetal cells. That is quite interesting. So, from what I understand, there is a genetic component, and as you mentioned, maternal lineage. So, it's really important to also collect family history. If you are someone who exhibits or experiences some of these symptoms, ask around in your family. See if anyone else in your family is also having those symptoms. And as we said, we don't always talk about these things because it's considered taboo a lot of the time. So just ask and let's help you figure out your symptoms. Well, Dr. Ahmed, we're going to have to take a quick break here, and when we come back, we'll continue this conversation. You're watching What's Up, Doc, and we'll be back after this short break.
A free online chat can give you the personalized tips you need to start boosting your retirement savings today.
Our fellow Americans.
Right now, the COVID-19 vaccines are available to millions of Americans.
And soon, they will be available to everyone.
The science is clear. These vaccines will protect you and those you love from this dangerous and deadly disease.
They could save your life.
So we urge you to get vaccinated when it's available to you.
That's the first step to ending the pandemic and moving our country forward. It's up to you.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3.
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
We are Justice for All. Headquartered in the heart of downtown Chicago, Justice for All is a global humanitarian initiative dedicated to raising awareness for human rights concerns impacting vulnerable minority groups. Our diverse team of staff and volunteers, led by Imam Malik Mujahid, work tirelessly to help Justice for All achieve their goals. We promote policies that protect religious freedom, address the root causes of mass displacement, and recognize the plight of refugees and forced migrants. Together, we can continue to stand up for justice. Justice for all.
Find out how to use an awkward silence to help a friend with their mental health at seizetheawkward.org.
Assalamu alaikum and welcome back to What's Up Doc. I'm your host, Dr. Aalia Al-Barwani, and today we are joined by Dr. Tayyaba Ahmed. She is a physical medicine and rehabilitation specialist who specializes in pelvic floor disorders and pain. So today we're talking about endometriosis, and before the break, Dr. Ahmed, we were talking about the symptoms of endometriosis, what distinguishes it from other things that can be disguised or masked, and what are some of the things that we need to be aware of or some red flags to bring up our pain and our issues and our condition to our provider. We also talked about the genetic component and how it does run in families and it is hereditary, so that's important to understand and to ask about in our family history. Now, is there anything that one can do? Let's say that they may be predisposed genetically to endometriosis, or they think that they may be at risk for it. What are some things that, if there are, that one can either do to prevent the onset or delay the onset, or maybe even reduce symptoms before thinking about coming to see a doctor or medications, etc.?
So unfortunately, there's no way to prevent it. However, because it is hormonally driven, a lot of different things that we don't recognize can convert to estrogens. So for instance, having a lot of soy in your diet is not necessarily a good thing when you have a history of endometriosis. So limiting the amount of soy, decreasing the amount of chemicals that have chemicals that are similar to the genetic of estrogen. So essentially trying to remove these products from your daily use, shampoos, etc., makeup that have chemicals that look similar to estrogen, and dietary plays a huge role. So for a lot of our patients, we recommend trying gluten-free, trying dairy-free, eating only organic meats, cutting out red meats, and then the soy. There are different supplements like diendomethylane, which is good for helping eliminate the estrogen from your body. So taking supplements like that. And then also, in terms of decreasing the symptoms, is kind of working on your pelvic issues before they become significant, where they're affecting your bowels and bladder and your sexual function.
That's pretty helpful. At least we know that there are some things to help mitigate, even though if it's if you're genetically inclined, there's nothing you can do to really prevent it. Now, you mentioned earlier that there is conclusive diagnosis and there is clinical suspicion. How is endometriosis diagnosed? What are some of the things, if a patient comes to you, or if you have to refer, what are some things that they should expect to have tested in order to be diagnosed with this, or to confirm diagnosis?
So typically a patient that sounds suspicious for endometriosis, I often have them read a book called Beating Endo. Most of these patients can read this book between a weekend, cover to cover. It's written by an amazing endometriosis specialist, Dr. Iris Orbach, and Amy Stein, which is a pelvic physical therapist here in New York. The book is great because it helps understand whether the wide variety of symptoms that a patient can present with endometriosis. Because when they often read this, anyone who I suspect endometriosis in usually reads this book and actually says, hey, this sounds like me. And then when they do believe that they could have it, because for many patients, just having a name to the diagnosis can be really rewarding, but it can also be very frightening. And so not wanting the name diagnosed officially, because of how scary that is and having to carry a disease manifestation with them, they're often very hesitant to meeting an endometriosis specialist because they're typically surgeons who want to remove the endometriosis. And that sounds very scary for patients. So they will often get an MRI pelvis that's done with and without contrast to see if there's any endometriosis. Now, bear in mind, majority of endometriosis is not picked up on MRI imaging because it is a small tissue. It is not a huge mass. If there is an endometrioma, that may be picked up, but that's not necessarily guaranteed because like we said previously, your symptomology doesn't necessarily match up. So you could have very terrible pain and have no endometriosis on your MRI because, first of all, radiologists are not trained to pick up endometriosis because it's so small. Another piece of imaging that can be done is a transvaginal ultrasound. But like we were saying before, transvaginal ultrasound could be very painful for many patients with endometriosis because of the tight musculature of the pelvic floor. So that may or may not be an option for some patients. And many times they don't necessarily pick up anything also because unless it's a big endometrioma or a hemorrhagic cyst, it may not necessarily be picked up on the ultrasound. So unfortunately for many patients, if there is a strong suspicion, many endometriosis specialists will go straight to a surgical laparoscopic option, which is essentially going through the abdomen with a robot to look and see around the abdomen, the pelvic cavity. And for many patients, they'll have a diagnosis of endometriosis clinically, but if it's not done under the proper care, they could have the wrong surgery, which is really important. And I guess this is an important time to mention the difference between excision surgery and ablation surgery. Essentially, an ablation surgery
so this is getting into the treatment now, correct?
Yeah. Well, it's kind of diagnostic, but usually when they do this, if they see endometriosis and it's an endometriosis specialist, they will go in there and actually take it out. Now, I've heard many stories of patients having the laparoscopic diagnostic surgery and being closed right up and being told that you have to go to a specialist because the GYN may not know how to take out the endometriosis. So that's where now you're needing a more therapeutic surgery versus a diagnostic surgery. But a good endometriosis specialist would be able to do all of it in one.
So it's really important to make sure that the person that you are seeing and is going to perform surgery, even if it's laparoscopically, would know what to do if they did find endometriosis, essentially, because you don't want to have to go through that again. You want them to be able to kind of take care of it all the first time they go in there. Is that what I understand?
I've heard so many stories. I had one today of patients who were constantly being told she had 5 surgeries, and out of the 5, she had 3 ablation surgeries and 2 excision surgeries. So an ablation is burning off the pieces of endometriosis that are visible. However, endometriosis is kind of like a mold where it grows below. And so if you don't excise it and remove it from the base, it can grow back. And the recurrence rate in an ablation surgery is much, much higher, almost in the 80% versus an excision in like the 7 to 12% recurrence rate. So it's a huge amount of, difference. And so for many patients, having one good surgery is way better than having 5 bad surgeries, obviously.
Oh, 5 is, yeah, absolutely. I completely agree with you. That's a lot. And so it's important to understand what you said is that the recurrence rate is higher with the ablation. And so in general, of course, it's going to be patient specific and what their surgeon is able to, or what they recommend. But excision sounds like it's going to be a safer bet for a lot of patients to prevent recurrence. And so as far as treatment options, well, we've talked about the diagnosis portion. And as you said, you mentioned the ultrasound, the vaginal ultrasound, and it had me thinking that, if you're saying that this can reach as high up as the lungs, which I actually have heard of as well, then really a vaginal ultrasound is really just looking looking through a microscope at something as opposed to kind of taking a step back and getting a better view. And so it kind of explains a little bit. We've talked about how there's a lot that is involved in endometriosis and a lot that can be that's elusive to the doctor in diagnosing it, that makes it such a difficult disease and difficult diagnosis to make. So there are so many factors, but being clued in and knowing this even is on someone's radar is, I think, a big first step. So I'm glad, again, just reinforcing how happy I am that we're here talking about this today. And with that, we do have to take a quick break here, and we'll be back and we'll keep talking about some other things related to this. You are watching What's Up, Doc, here on Muslim Network TV, and we'll be back after a few minutes.
A free online chat can give you the personalized tips you need to start boosting your retirement savings today.
Our fellow Americans.
Right now, the COVID-19 vaccines are available to millions of Americans.
And soon, they will be available to everyone.
The science is clear. These vaccines will protect you and those you love from this dangerous and deadly disease.
They could save your life.
So we urge you to get vaccinated when it's available to you.
That's the first step to ending the pandemic and moving our country forward. It's up to you.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3.
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
We are Justice for All. Headquartered in the heart of downtown Chicago, Justice for All is a global humanitarian initiative dedicated to raising awareness for human rights concerns impacting vulnerable minority groups. Our diverse team of staff and volunteers, led by Imam Malik Mujahid, work tirelessly to help Justice for All achieve their goals. We promote policies that protect religious freedom, address the root causes of mass displacement, and recognize the plight of refugees and forced migrants. Together, we can continue to stand up for justice. Justice for all.
If I could be you, and you could be me for just 1 hour. If we could find a way to get inside each other's minds. If you could see you through my eyes instead of your ego, I believe you'd be surprised to see that you've been blind. Walk a mile in my shoes. Walk a mile in my shoes. Yeah, before you abuse, criticize and accuse. Walk a mile in my shoes. Walk a mile in my shoes. Well, before you abuse, criticize and accuse. Walk a mile in my shoes.
Find out how to use an awkward silence to help a friend with their mental health at seizetheawkward.org.
Assalamu alaikum and welcome back to What's Up Doc. I'm your host, Dr. Aalia Al-Barwani. Today we are talking about endometriosis and we are joined by Dr. Tayyab Ahmed. So before the break, Dr. Ahmed, we were talking about essentially what are some ways that we can conclusively diagnose endometriosis, and decided that there really is a lot of clinical suspicion that sometimes you will start treatment on or having to get that laparoscopically confirmed, which is with the robotic surgery that you mentioned. Now that we've kind of gotten through some of the reasons behind it, we kind of said that it was genetic was the biggest component. We talked about the diagnosis itself, symptoms, diagnosis. We're at treatment now. And I know that you primarily treat this in the office with several different methods. It's not a straight cookie cutter approach to every patient, of course. And as with everything, I wanted to make this disclaimer that every patient should, of course, have this discussion with their provider. But I am interested in seeing how you treat it and your perspective, especially as a PM&R physical medicine and rehabilitation specialist, which I love your perspective as opposed to an OBGYN who may have a different approach to treating this. You are addressing the pain that comes along with this, along with some of the other symptoms. So share with us, please, what are some ways that you treat your patients?
Sure. So because I'm a physiatrist, a lot of my training was done in the bones, the joints, the nerves of the pelvis. Essentially, when patients are having pain, they tend to find themselves in the fetal position, causing a lot of compensation on their body. When patients are immobile because they're due to pain, they tend to clench their abdomens, they clench their pelvic floors, causing disruption in their urinary system because their pelvic floors are holding tight onto that urethra. They're also holding tight onto the bowels, so having a bowel movement is difficult and making sexual function difficult. For some patients, treating the endometriosis means taking out the endometriosis and praying that there is no recurrence. But for some patients, they don't just have the endometriosis, they also have these other symptoms in their bowel, their bladder, and their sexual function. They may also present with groin pain, which comes from a lot of bearing down. They could have neuralgia around their ilioinguinal nerves, which are in their groin, from their hips all the way down to their pubic bone. They could have scar tissue and adhesions causing pain in their lower abdomen. They can also be compensating in their hips, which can eventually lead to a labral tear. So they might present with pain with walking in their hips. They might have referred back pain. They might have pain referred down their legs as far as their toes. So for many patients, this can be a full body, condition that is multifactorial, multifaceted, and treating all of the symptoms. So in terms of treatment, we have to see what their symptoms are. So if they're presenting with pelvic floor dysfunction, I start with different medications, first I always start with pelvic physical therapy. Many patients do not know pelvic physical therapy exists. And in a quick one-liner, pelvic physical therapy includes internal and external manual work on the muscles inside the pelvis. So that's the pelvic floor. They can be accessed rectally or vaginally in females, and in males, they can actually only be accessed rectally. But patients with endometriosis also have abdominal pain. So working externally manually with their hands, physical therapists can manually teach patients how to do a massage to help the bowels moving. They can help patients breathe, teach them how to do diaphragmatic breathing so that they can, when they're in a pain flare, they can try to get out of it. Many patients with endometriosis are comforted by heat. So hot baths, Epsom salts baths, which have magnesium in them, are great to decrease the spasms in their muscles, which happen when people are in pain. Because when your body is in pain, your muscles tend to clench up, whether it's in your pelvic floor, in your abdomen, even in your arms and your legs. And so when muscles are tight and short, they don't have energy and they create there's a decrease in the pH, which causes acidity and then inflammation. And so when this happens, heat is a really good thing. Muscle relaxants are good to decrease that tension in the muscles. There are trigger point injections and nerve blocks that can be done to block the nerves of the pelvis and decrease the muscle tension in the pelvic floor. There are nerve medications that work on the nerves of the pelvis, but also on the nerves of the entire body. When patients have been in pain for 20 plus years, your brain starts to feel like this is your new normal, and getting out of that new normal is really difficult. And so many patients need help of neuropathic medications to remind the brain what it's like not to be in pain. Meditation is key. For many of our patients, I recommend anything that reminds their body they're not in pain, whether it's praying or singing or coloring, or doing an activity that just makes them feel good and forget about their pain. As well as yoga. Yoga is a great, exercise. And there are some exercises or activities like swimming in warm water that can help relax the muscles as well. So it's not, you're not limited by anything, but doing things that help you breathe through your pain and get you out of your pain. So there are many, many options aside from the classic hormonal treatment that many gynecologists would recommend for endometriosis. And many of my patients prefer not to be on hormones. And so that's why having the options I do have, whether they're medications or suppositories or creams, are really important, because we can get them their medication options vaginally or topically without necessarily having to take it by mouth.
I love that. I love that you have these alternative ways to treat this without having to jump to medications first, because as you said, it really depends on the symptoms that the patient is experiencing. Now, I do want to touch on one thing that you mentioned earlier in this episode, which is that there is a percentage, even though low, that some of these endometriosis lesions can become cancer. And so with that in mind, would you agree that it's really important to make sure that these lesions are excised, because there is that chance, even though small?
Yeah, 100%. So for some patients, fertility may not be important. Their presentation of endometriosis may only be limited to 2 days of menstrual pain, maybe a little bit of constipation that's treated with magnesium or pelvic physical therapy. And patients will often ask me, is there any harm in just leaving the endometriosis inside? I don't want children. I don't care if it affects my fertility. You're not going to die from endometriosis. However, there is a risk that it can become ovarian cancer. And in that scenario, it is dangerous. Is it a high percentage? Not really. But if you have a family history of that, I would definitely consider excising the endometriosis. But it also can affect you hormonally when you have menopause. So God willing, you get to menopause, you don't want to have any issues with that also. So that's why excision is the gold standard treatment for endometriosis.
Excellent. Now, you did mention hormonal suppression, hormonal treatment, and I know that you are not a big fan of this. And of course, as I said, every patient should have this discussion with their provider. But let's talk briefly in the few minutes that we have left about that. Why are you not a fan of it, and what are the pros and cons of that?
So what I'm not a fan of is hormonal suppression that puts a patient into menopause. There's a difference between birth control, and there's a difference between some of these more aggressive medications like Lupron or Orlissa. Many times patients, pharma companies are recommending patients skip the excision surgery or ablation surgery and go directly to a hormonal suppression, which essentially is shutting down the ovaries to cause early menopause. So patients as young as their 20s are going into early menopause. However, that's very detrimental to their their health, in terms of their bone health or their mental health, having hot flashes when they're only 20 years old. So that's different than going on oral birth control. Many patients will also go on oral birth control before they start a hormonal suppression, and take continuous birth control, which I'm okay with if the person is okay with, because that's not necessarily causing, permanent side effects, whereas Orlissa and Lupron can cause permanent side effects in a person's body. When it's birth control, they may still have mood swings, weight gain, sexual side effects. However, that's not necessarily causing things that will be, and it may or may not help their pain, but it's definitely something to try. And every person is very different in their age, when they get their diagnosis, what their situation is, whether they're interested in children or not. So it's really important to make sure you fine tune your treatment plan according to what you need.
And that is an excellent point to make at the end here and to end on. So I completely agree that it's very important for you to understand for you to have discussion with your provider and to understand what is it that you want to get out of the treatment. Because as you said, every person has a different outcome and a different thing that will make their quality of life better living with endometriosis. So that is an important point to make there. And I also want to make sure that we share that Dr. Ahmed is not endorsing or sponsoring or supporting any particular medication. She's not being paid by another company to say things about a different one. This is just her clinical experience that she's sharing with us. And we do very much appreciate that, Dr. Ahmed. We appreciate the information that you've shared with us today. And we wish you every success in your career.
Thank you so much. I truly appreciate being here. And I hope that we've helped some women, and inshallah, they pay it forward to the next generation.
Ameen. Thank you for joining us in another episode of What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and I'll see you next time on another episode of What's Up, Doc.